Welcome to the April 2024 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. My name is Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series. This month, we're going to do something a little different from our usual format.
That's right, Alice. In the April issue of Diabetes Care, there's a special collection of 10 papers from the comprehensive Glycemia Reduction Approaches in Type 2 Diabetes, a comparative effectiveness study, also known as GRADE, and sponsored by the National Institute of Diabetes, Digestive and Kidney Diseases of the National Institutes of Health. Therefore, instead of interviewing authors from feature articles selected by the editors of Diabetes Care this month, we're going to conduct a group interview to discuss learnings from all 10 of these GRADE study papers.
In addition, we'll have a special interview with none other than the Dr. David Nathan, who is featured this month in a beautifully written Profiles in Progress feature by Dr. Deborah Wexler. That segment will kick off with a brief discussion with Dr. Wexler, and as you're listening to the interview with Dr. Nathan, bear in mind that at the time of the interview, he had no idea that the Profiles in Progress piece had been written about him. So now that you're listening to this full episode, David, surprise!
And after all that fun, Alice and I will do our rapid exchange segment where we give brief summaries of other articles from the April 2024 issue that we found of particular interest.
So with that setup, let's dive into this special episode of the April 2024 issue of Diabetes Care.
In the April 2024 issue of Diabetes Care, there's a special collection of 10 papers from the GRADE study, which stands for Glycemia Reduction Approaches in Type 2 Diabetes, a comparative effectiveness study. This study was sponsored by the National Institute of Diabetes and Digestive and Kidney Diseases of the NIH. And to discuss the latest results from this study and their clinical and research implications, we are so pleased to be joined by Dr. David Nathan, Professor of Medicine at Harvard Medical School and Director of the Diabetes Center and the Clinical Research Center at Massachusetts General Hospital. David is also the chair of the steering committee of the GRADE study. In addition, we have Dr. Jennifer Green, Professor of Medicine and Endocrinology, Metabolism and Nutrition at Duke University, and an associate editor for Diabetes Care. And last but certainly not least, we've got Dr. Matthew Riddle, Professor of Medicine and head of the section of diabetes at Oregon Health Sciences University. Matt is a past editor-in-chief of Diabetes Care and continues to serve on the editorial board. Welcome, and thank you for agreeing to be part of this special podcast covering your work on the GRADE study.
So, David, I'm going to start with you. The original design and the rationale paper for GRADE was published in 2013. with the glycemic, microvascular, and macrovascular outcomes papers coming out in 2022. So can you briefly summarize for our listeners what was the purpose of the GRADE study and what were some of the top-level findings back in 2022?
Well, first, Alice and Mike, thank you for hosting this podcast. When we started planning GRADE, really almost 15 years ago, the epidemic, really a pandemic, of type 2 diabetes was in its ascendancy. And as a result, new diabetes medications were being introduced at a rapid rate. Unfortunately, there were very few, if any, studies that directly compared the most common medications. Therefore, GRADE was designed as a comparative effectiveness study that would perform a rigorous head-to-head comparison of the most commonly used medication classes in type 2 diabetes. The 4 classes of medications would be added to metformin, which was and remains the consensus background medication recommended for most patients with type 2 diabetes. The 4 medications were insulin glargine, the sulfonylurea glimepiride, the GLP receptor agonist liraglutide, and the DPP-4 inhibitor sitagliptin. The major study outcome was the failure to maintain a hemoglobin level less than 7%. So if they went above 7%, that was considered the outcome. In addition, we wanted to examine other features of treatment and compared the development of complications, including cardiovascular disease events, across the 4 medications. Finally, we purposefully recruited a highly diverse study population reflecting type 2 diabetes in the US in our 36 centers. They had a wide range of ages, men and women, and about a third of our study volunteers self-identified as African American, Hispanic, American Indian, or Asian American. And with that distribution in the population, we were able to examine whether specific medications would work better or worse in specific subgroups of the population. So that's the background. The major findings that were published in the New England Journal showed the following. First, we showed that glargine insulin and liraglutide were more effective than the other two glucose-lowering medications in keeping hemoglobin A1C less than 7% over the 5 years of the study. Of note, although hemoglobin A1C initially fell in all of the treatment groups to less than 7%, it rose to a little higher than 7% on average by study end. The majority of all participants ended up with hemoglobin A1C levels greater than 7%. Regarding the secondary outcomes, the vascular complications, there were no differences in the effects of the different medications on microvascular disease, including kidney disease and peripheral neuropathy. But liraglutide had a significantly lower risk of any cardiovascular disease, and that the definition was that it included a combination of fatal and non-fatal cardiovascular disease, heart attacks and strokes, unstable angina, or heart failure requiring hospitalization, or any revascularizations. So again, liraglutide did have a significantly better outcome than the other three drugs. GRADE is one of the few studies that has demonstrated a cardiovascular benefit of the GLP receptor agonists in a low-risk population.
Well, that's really great, David. And I want to turn now to Jennifer as a clinician and researcher to think back to that point in time when the original GRADE results came out, and how did you interpret those in terms of implications for clinical practice?
Oh, thank you so much for the opportunity to discuss the GRADE results. There's really quite a lot to consider in the translation of the GRADE findings into clinical practice. And I think I may just put those into a few different buckets, including the effect of the interventions on hyperglycemia, on rates of hypoglycemia, and on complications. And has already been mentioned, it was perhaps unsurprising that the injected medications, that is insulin glargine and liraglutide, were found to have the greatest glycemic efficacy. However, we still saw deterioration in glycemic control over time with all of the agents that were studied, including those. And this reinforces, in my mind, the need for prompt intensification of glycemic therapy rather than waiting until obvious treatment failure has occurred. We know that diabetes is a progressive disease. We've seen that again in GRADE, and we should not assume otherwise, even though we are using potent therapies or newer therapies. Now, from the hypoglycemia perspective, I do think it was very important that we identified a higher rate of severe hypoglycemia, which is an outcome to be avoided wherever possible, with use of a sulfonylurea compared with the use of basal insulin. So this is a very important finding, particularly given the frequency with which sulfonylureas continue to be prescribed in this country and worldwide. And perhaps this should be very seriously reconsidered in light of the GRADE findings. And then finally, from the complications perspective, Dr. Nathan has already mentioned that from a microvascular perspective, it perhaps wasn't terribly surprising that we didn't see major differences in the rates of microvascular complications between the treatment groups, because there weren't really major differences in glycemic control between those groups during the course of the study. But I also agree that the suggestion of a cardiovascular outcomes benefit with liraglutide therapy compared to all the other treatments combined is really quite interesting, as we know less about the cardiovascular effects of individual diabetes medications in people with diabetes at lower cardiovascular risk, as was the case for the participants in GRADE. And maybe this is a suggestion that we can make choices to mitigate cardiovascular risk at earlier stages of the disease.
So thank you very much, Jennifer. That was a great synopsis of our clinical interpretations at that point and the powerful implications. And that was 2022. So now we can sort of fast forward to 2024. And as mentioned, there are 10 papers that were included in this April issue of Diabetes Care. And Matt, you were tasked with serving as associate editor for the journal for all of these papers. And before we dive into details then from the various articles, what was your general impression from the collection? Because you got to sort of see all of them, serving as a bit of foreshadowing, I guess, for what we're going to discuss in greater detail for the rest of this episode.
Well, first, thanks for asking me to comment on this study. It's an important one, and it's unusual to have so many secondary analyses after the main report appearing in one journal and in a grouping that you can comment on it all together. So I think GRADE is an important study. I have to emphasize that we don't have in the diabetes world all that many randomized, adequately powered, relatively long-term comparative effectiveness studies. And GRADE fills that gap. And it addresses an important question, which is how we should be thinking about adding additional therapy after metformin and lifestyle treatment are no longer doing the job for type 2 diabetes. It's a common clinical situation that we haven't had very good guidance on addressing in the past. Now, all important, well-designed studies like this have a primary endpoint that is the focus of attention. And you've mentioned the main outcomes and a few of the details from the original reports that were published 2 years ago. I find the outcome to be really quite encouraging in a way that hasn't been mentioned yet. And that is that all of the interventions, all of the 4 drugs tested, had relatively good effects. We had experience with them, so this isn't a big surprise. But the glycemic control achieved over time was very similar with all 4 of the treatments, a small advantage, a therapeutic benefit of perhaps 15 to 20% in duration of glycemic control being maintained with insulin and liraglutide. But that's something we really knew. And the other drugs, glimepiride and sitagliptin, really did quite well in addition. And furthermore, there were no new surprising findings of adverse events that we didn't know about. All of the drugs have relatively good safety records in the study. And so it's a reassuring study for people who take care of people with diabetes in the big world, because none of these drugs is clearly worse than all the others, and none is clearly dominant over all the others. They all can be considered reasonable treatments at the time of metformin failure. But the goal of the investigators, and they very clearly stated that in the early papers from GRADE, wanted to give as much guidance as possible to individualizing therapy so that the individual treatment could be matched as well as possible with the individual person with diabetes. And really, that's what we're now talking about. The primary papers didn't deal in great detail with the specific advantages and limitations of each of the drugs, but these 10 additional analyses do that. They include analyses that look at patient-reported outcomes. They include pathophysiologic mechanisms, and they also address other endpoints beyond the glycemic endpoint that was the primary endpoint in the main trial. So why does this matter? Well, most big studies like this one, let's say the UKPDS and the DCCT being examples, have both an important message from their primary endpoint, but also sometimes unexpected, or in any case, supplementary findings that turn out to be almost as important as the main endpoint. So in the UKPDS, you'll remember, for example, that was the first study that demonstrated the relentless progression of type 2 diabetes that was unaffected, not slowed down by any of the treatments used there. And that finding was actually present here in GRADE as well. The DCCT showed that glycemic control reduced microvascular disease in a way that really changed our world when it was reported in 1993. But it also showed that there's a metabolic memory with lingering, ongoing effects after the cessation of more intensive treatment in the intensive arm. So the secondary observations and studies are often very important, sometimes surprisingly so. Well, I think that's true in GRADE 2. And I don't know, I think probably David is going to be talking a little bit more about insights into individualization of therapy. But I'm going to raise another question toward the end of our talk here, which has to do not with just the choice of drug, but the process of making individualized decisions. It's not easy to do, and I think Grace helps us think about this.
That's really wonderful, Matt. So while we won't be able to take a deep dive into each of the 10 articles, we certainly hope that we'll be giving our listeners a high-level perspective to whet their appetite to read and dig into the full collection of papers that get at all of these nuances of selection and individualization for the patient in front of you when you're making that decision to pick the next therapy in their armamentarium. And I'd like to start our discussion of these secondary papers with the negative glycemic endpoint that was used, that was made up of a composite outcome of either glycemic deterioration defined by the hemoglobin A1C going above 7.5%, or the development of weight gain that was defined by more than 5% weight gain for an individual, or the experience of severe hypoglycemia or recurrent non-severe hypoglycemia. And so these, of course, are all patient important outcomes that we all try to minimize and hope to avoid when we're prescribing new therapies to treat type 2 diabetes in our patients. And so, David, I want to turn it back to you and get your impression on how the 4 treatment arms of GRADE differed for this composite patient-centered outcome that was used as the composite in these secondary analyses, and what your expectations, or were you surprised by the findings?
Well, Mike, thank you for that question. So, of course, hemoglobin A1C is an important outcome, especially because, as Matt has mentioned, it's importantly linked to long-term complications. However, there are lots of other considerations that go into the selection of medications, including side effects such as hypoglycemia, weight gain, and others as well. One of the things that we haven't yet looked at is cost effectiveness, which we have analyses that are ongoing, and that's going to be very important. But for this paper, we looked at, as you mentioned, a composite outcome, and it showed, that generally the powerful effects of lowering A1C, plus the low frequency of hypoglycemia and the beneficial effects on weight loss, made liraglutide kind of the winner in this respect with regard to the composite outcome. On the other hand, the sulfonylurea glimepiride was probably the worst performing because it not only was not the most potent drug to lower A1C, but it was associated, interestingly, with the highest frequency of hypoglycemia. Insulin was not, by the way. It was sulfonylurea that was. And in addition, it was associated with some weight gain. So that was a little surprising, actually. I think everyone would have expected that insulin therapy would have resulted in the highest risk of hypoglycemia, but that wasn't the case. So while glargine insulin had the most powerful effect on reducing glycemia, its effect on weight gain and slightly increased risk for hypoglycemia lessened its composite score. As I mentioned earlier, these are all important considerations in selecting drugs. I should point out, as Matt mentioned before, all of the medications were found to be generally pretty safe. And this is, even though there wasn't dramatic differences among the medication groups, knowing that they were safe and well tolerated means that we can turn to these other outcomes when we select a medication for an individual. In addition, as we'll talk about in a little while, I'm sure, we did identify some subgroups that might respond better or not or worse to a given medication.
And all of those other outcomes is not the right word. Those other experiences that the patients would end up having from the therapies really are critical to helping us make choices. So I appreciate that insight. And then another article within the collection talked more about the natural history, if you will, of diabetes. So as we know, the natural history of type 2 diabetes, glycemic levels tend to increase over time. We've seen that now in multiple studies, and people will require advancement in therapy. And in the GRADE study, you built in rescue insulin, which was glargine, or for the glargine arm, aspart. And they were supposed to be started within 6 weeks of confirmed A1C greater than 7.5%. And interestingly, nearly half of the participants met that threshold over the course of the study, really speaking to the natural history of type 2 diabetes itself. However, only 39% of the participants who met threshold actually had rescue glargine added within 6 weeks. And only 14 to 19% of the participants who met threshold had rescue aspart insulin added to their basal insulin within 6 weeks. So, Matt, what are your thoughts about this analysis, and what are the takeaways for you with respect to the insulin delay, I guess, in insulin initiation, even in the context of this study?
Well, first, I admire the great investigators in trying to think through how to get the most information they could in the design of this study. And as you just mentioned, there was a secondary endpoint beyond the 7% hemoglobin A1C endpoint that was meant to compare the glycemic effectiveness of the four treatments. The secondary endpoint was further progression to hyperglycemia above 7.5% and confirmed. Now, there are really, I think, two reasons for having this secondary endpoint in place. The first was that it was used as a trigger for intensifying therapy, essentially rescue therapy, to try to protect the patients and get the best possible medical outcomes, protecting against chronic hyperglycemia in any of the patients in the study. And the other was to determine whether, with insulin being used as the rescue therapy, whether there was going to be a difference by original treatment assignment in the effectiveness of the addition of insulin. So it was a good rationale for this. And patients, of course, many of them did progress to this higher level of glycemia. However, the insulin rescue protocol wasn't rigorously followed. In fact, as you said, less than half the people did it exactly as was recommended in the protocol, really mandated by the protocol. So what does this mean? Well, one of the effects of that is that it makes further analyses of outcomes, both safety and efficacy outcomes, after the initiation of the rescue protocol less reliable. It really confounded the interpretation of those further outcomes. But on the other hand, the patients in the study, it turned out to be very well managed. They were not following the protocol all the time, but their hemoglobin A1C ended at 7.1% in all four of the randomized treatment groups. So something was being done right within the study. The experienced investigators and the highly motivated patients made decisions about really tertiary treatment, that is, adding a third agent or intensifying one of the other treatments in such a way as to regain or maintain control. So it was a clinical success, although the protocol wasn't followed exactly as written, which was very disturbing to some of the reviewers of these papers that were submitted to Diabetes Care. But I think this is unexpectedly an important insight that is provided us by this feature of the trial. So my interpretation of this is that the likely reason the protocol for rescue was not followed by the investigators and the patients as written was that they saw better ways for the patient to combine drugs depending on the individual patients. So it's individualization at the third treatment level, another problem that hasn't been addressed in studies, and probably an important one. In other words, it raises the question of what to do when patients get beyond the two-drug intervention and need to have more complex therapy. My opinion is that it has implications for how we structure clinical practice and the process of individualizing therapy for type 2 diabetes.
If I might add a little bit, GRADE was designed to be as realistic clinically as we could possibly make it. We used medications that were approved by the FDA in combination with metformin. We had guidelines and we had a plan as to how to transition people when they didn't reach the goal. And as Matt pointed out, there was a little bit of slowness in taking this up. But in fact, it was usually predicated on discussions between the investigators, serving here as research clinicians, if you will, and the participants who were able to say, give me a little more time on this. And that's when we looked and tried to determine why the delays were there. And that's pretty realistic for clinicians. Patients aren't quite ready just because you say do it, doesn't mean they're going to do it. And to me, it reinforces that this was a realistically designed trial. But what the paper shows is that there was some slowness. There weren't machines. They didn't just change when we told them to change, that they had their own ideas about it. And as Matt points out, it suggests that we have to individualize our approach with our patients, obviously.
Yeah, and I was just going to say, David, how much that reminds me of my experience in clinical practice, and particularly at the point of adding a third agent. I mean, and whether it's for glucose control or cholesterol control or blood pressure control, most patients, by the time they're on two, are more wary about saying, all right, do I really need something else here? Could you give me a little bit more time? I think this was working for me. Could I have a little bit more time? And so I would totally agree that it mirrors what I think we all experience in our care and management of patients with type 2 diabetes, and makes a very
Right.
realistic result from these studies.
So the one part of it that wasn't realistic is, of course, that there were no cost implications to the participants. The medications were provided free of charge. So you can even imagine that that was a little bit idealized compared to in the real world, where people may be stuck, depending on how much insulin is going to cost these days, but stuck with yet another medication that they're expected to pay for. That wasn't the case in GRADE.
Now, let's switch gears and talk about the predictors of glycemic deterioration over time. And so here's another example where this was seen yet again in a large study of type 2 diabetes. And here we have the opportunity to get into potentially some more of the mechanistic insights. And so there was an analysis of baseline characteristics that found on multivariate analysis that younger age, higher hemoglobin A1C, higher fasting glucose at baseline, and treatment group assignment were each associated with greater likelihood of glycemic deterioration. And in addition, insulin sensitivity and beta cell function predicted risk of glycemic failure, with differential effects as well for each of the treatments on beta cell function response. David, turning to you for this, can you expand on this further and discuss the potential clinical implications of these physiologic differences that may have impacted the glycemic deterioration or slowing of that deterioration by treatment assignment?
Sure. So, as we all know, one of the major challenges of treating type 2 diabetes is that although we know it is a heterogeneous disease, despite that, we generally treat all patients with type 2 diabetes as if they have the same disease. They all get treated the same. We follow the same consensus algorithm, for example. GRADE, one of the major design features of GRADE, was that we wanted to start trying to look at subgroups that might respond differentially to different medications. So the results of the multivariate analyses support using several simple demographic factors clinically available, such as age and initial A1C, as a way of directing patients to a specific medication. For example, a younger patient with high initial A1C should probably be steered away from sitagliptin and towards the demonstrably more effective medications, insulin glargine or glimepiride, for example. Measurements of insulin sensitivity and insulin secretion compared with demographic variables, for example, are not measured routinely in clinical practice. However, the GRADE results really do provide or begin to provide a window into their potential utility in clinical practice. For example, participants with relatively lower levels of insulin secretion, maybe not surprisingly, and measured as C-peptide secretion, or higher insulin resistance failed sitagliptin again earlier. So these findings may help predict who is most likely to fail some of these medications. And I think they will end up, hopefully, steering us so that we can provide greater precision medicine, greater specificity when we treat individual patients.
Thank you for that, David. Now, in the collection, there were also several papers on emotional distress and health related quality of life within GRADE, which I was very happy to see. And I mean, to summarize on a very high level, they found that emotional distress was associated with decreased medication adherence, which I think makes sense, but interestingly, not vice versa. And thankfully, the presence of emotional distress was not associated with glycemic deterioration. But one of the things that I was surprised by, and in a good way surprised, was that all of the treatments were actually associated with less emotional distress overall, and there was no decrease in health related quality of life. And that included insulin, which is, I think, perhaps one that one would have thought would have a negative impact. So, Jennifer, what are your thoughts on this, and what does this mean to you as a clinician?
Well, Well, that's right. We found that having higher levels of depressive symptoms and diabetes distress at baseline were characteristics associated with lower medication adherence over 3 years. And it also appears that participant concerns about their diabetes medications were an important factor here. And if we think about that specifically, to me, that suggests that providing people with diabetes the opportunity to discuss those types of concerns and to deliver appropriate counseling and response regarding medication costs, side effects, or safety might be important in improving medication adherence. And we may, in fact, need to revisit what medications we're recommending to individuals with such concerns. Now, as you've also mentioned, some of the other analyses actually identified decreases in diabetes distress and depressive symptoms with any of the study treatments that were included in GRADE. And I think what that means to me is that we should not withhold indicated additional therapies out of a fear that we're going to increase diabetes distress or worsen mood or quality of life, or because we think that patients with those issues will not benefit from treatment intensification.
That's really great. And there was also an analysis in GRADE on mortality. And to that point of worrying about what recommendations are being made in terms of longevity. And I want to turn back to you again, David, and hear your key insights from the mortality analysis from GRADE.
Yeah, so the mortality paper is a brief paper because the results were pretty clear. The first thing is that the mortality results revealed that the mortality rate was really quite low. And maybe not surprising considering, that it was a relatively healthy population that we recruited with type 2 diabetes distributed across ages, sex, and racial ethnic groups, but still generally pretty healthy. Not surprisingly, also, most of the mortality was related to cardiovascular disease or cancer. I mean, that's also not a surprise. Of note, there were no significant differences among the medications. So here we see no difference, even though liraglutide did have this benefit with regard to cardiovascular disease. But again, the number of events, we were not powered to look at this. Again, if we wanted to look at mortality, we would have selected probably a much older, infirm population, but we didn't. That wasn't the goal here. Considering the overall low mortality rate, the absence of differences between the different medications is just not surprising. So again, this is reassuring and not unexpected.
So there was a lot of new information derived from the GRADE study and included in this April 2024 issue of Diabetes Care. And before letting David give us his final words of wisdom, I'm going to ask you, Matt, about something that you wrote about in your commentary and you sort of alluded to earlier in one of your answers. You talked about the real world setting and whether or not the individualization required can take place in primary care. So can you expand on that, please?
Yes, I find this aspect of the GRADE data really quite fascinating. It's a well-known phenomenon that in clinical trials, the metabolic outcomes are generally better in treatment of diabetes than they are in clinical practice. And this is attributed to the fact that the patients are selected, the study participants are not like everybody else in the bigger community, and also to the fact that protocol oversees the management, insists on treating the patients as well as can be done in the study. But I think it goes a step beyond that. It has to do with the fact that the treatment of diabetes is becoming more complicated and nuanced as time goes by. We have increasing numbers of new drugs. We have multiple formulations of several of them with different dosing patterns and different indications by the regulatory agencies. These drugs are wonderful. They do remarkably good things, but having them proliferate and being used for specific aspects of the metabolic arrangements of diabetes creates a problem for the clinician. It's just difficult for a primary care doctor who is in a scheduled environment where patients come through every 10 or 15 or 20 or 30 minutes, a very limited time to perform the tasks of evaluation and advice and decision making. And so I think that accounts for a good part of the difference between the in-study outcomes and the clinical practice outcomes. So I thought about this a good bit. We have quite a tradition in medicine of identifying specific kinds of medical problems that are best suited to longitudinal specialty care with groups of doctors with greater specialized experience and abilities dealing with certain aspects. So this is true for dental care, which is performed by dentists, and eye care, which is performed by ophthalmologists, and reproductive health care, which is done by obstetricians and gynecologists, and so on. There are many specialties that are structured into our system, allowing specialized evaluation and intervention. Now, this has been thought to be inappropriate for diabetes. That is, primary care doctors ought to be able to see type 2 diabetes and make good decisions. But it's getting harder over time as there are more drugs and we know more about subgroups of people with diabetes. So I think that one of the take-home messages for me from the GRADE study is that once you get past the first 5 years of treating diabetes with lifestyle intervention and metformin, which can be very appropriately used for every patient with a new diagnosis of diabetes. And then after the second drug is started, the population which was being studied in this trial, then it starts getting complicated. And it's going to require more sophisticated decision making, more time with the patient, opportunity to interview the patient and the family about the lifestyle and the living circumstances and the financial support and the emotional support, and clues as to pathophysiology underlying the individual patient's diabetes. All of these things take time to evaluate and expertise. And I believe it needs to be done in the future, not just in primary care, but in specialized diabetes centers. There's another study that gave me this same feeling when I was involved in it some years ago, and that was the Origin study, which was a larger and longer comparison of two intervention approaches. The one arm was a randomization to insulin glargine as the initial therapy. The other was step therapy with oral agents, and it was looking at safety and effectiveness of glargine in comparison to what was then standard treatment of type 2 diabetes very early in the natural history of the diabetes. And what was shown was that with observation of patients every 3 or 4 months by experienced clinicians who knew about diabetes, that hemoglobin A1C of 6.5 at entry was maintained for more than 5 years of follow-up in the study, 6.5% after, I think it was 9 years average duration of diabetes in this 11,000 participants. So what was similar between the Origin study and the GRADE study was an experienced investigator group who had access to the patients and saw them on a regular schedule and were expected to try to maintain control. What's different between GRADE and the Origin study was that in GRADE, there was a specific protocol that was recommended for insulin-mediated rescue therapy, whereas in Origin, the investigators were supposed to use their judgment and make good decisions with the available treatments. Both groups got to the same place in terms of good control and safety of the patients. But I think in the case of the GRADE investigators, it happened because they knew what they were doing, not because the protocol was a superior algorithm for managing diabetes. I think we need to find ways within health systems in this country and elsewhere to have experienced, trained specialists in diabetes management who can be seen by patients with type 2 diabetes as well as those with type 1 diabetes. It's not the way things are structured now. I think we're going to have to go that way, and the GRADE experience argues for that.
That's really great, Matt. I fully agree having that access to specialized diabetes providers for our population with type 2 diabetes wherever they reside and however is most convenient is really essential to implementing the benefits of intensified and increasingly complex therapies that are now available to treat individuals. And I'll give the final word now to David. Considering the totality of the information that's come out of GRADE, what do you want to have clinicians and researchers take away from our discussion?
Yeah, so thank you, both of you, for hosting this again. First, I want to point out that comparative effectiveness research in type 2 diabetes is really rare. I mean, Matt mentioned Origin study, the ADOPT study, but I mean, you can count them on the fingers of one hand, basically. We are indebted, of course, to our participant volunteers, without whom, of course, the study would never have taken place, and also to the NIDDK for seeing the importance of GRADE and making it possible. The GRADE investigators were an extremely talented and dedicated group and worked closely together to make GRADE successful. Although the pharmaceutical industry hasn't traditionally supported such studies, I need to really give them credit. They didn't have any role in designing the study, didn't influence it at all, but they did generously contribute the medications. And without that, we couldn't have done it. Second, the GRADE results, I hope, begin to provide some insights into precision medicine. As we mentioned earlier, patients with type 2 diabetes are treated kind of uniformly. And I think that the results published in these 10 papers begin to reveal, through a rigorously performed study, which medications might be most effective in which patients with type 2. And we're just starting that process. And we still need to look at cost effectiveness, I think further analyses of the GRADE data, along with the development of clinician-friendly tools, perhaps based on AI analyses that utilize clinically available data, should help to refine the treatment of type 2 diabetes. And in the end, if we can contribute to that, I think the GRADE will have been well worth it. I also want to point out something that Matt has said, and Jennifer as well, and that is that, demonstrating these comparative effectiveness studies, it's not a placebo control. You expect that active therapies will behave more similarly than not. These are all approved drugs based on their A1C lowering. But I think that even showing that the drugs are the same for some patients is an important observation, that it's not a question of choosing one over the other in all cases. Sometimes you can choose them based on, as I said, cost effectiveness, the outcomes that were the joint outcomes in terms of hypoglycemia and weight gain. There are a lot of factors that we're identifying that I hope will help guide the more rational choice of medications for the treatment of type 2 diabetes.
So thank you to you, Dr. David Nathan, Dr. Jennifer Green, Dr. Matt Riddle, for joining us today for this discussion about the special collection of grade papers from the April 2024 issue of Diabetes Care. Thank you for your valuable insights, and we encourage the listeners to get more details from the full papers. Now that we've heard the great insights from the comprehensive and far-reaching GRADE study, let's take a pause to reflect on another important feature from the April 2024 issue of Diabetes Care. It is a beautifully written Profiles in Progress piece about the man himself, Dr. David Nathan. It was written by Dr. Deborah Wexler, endocrinologist, chief of the Massachusetts General Hospital Diabetes Unit, and associate professor of medicine at Harvard Medical School. It is wonderful to be joined now by Dr. Wexler, who will share some additional insights and stories, I hope, about Dr. Nathan, which will be the perfect lead-in to an interview that Mike and I conducted with Dr. Nathan. Now, note that at the time that we interviewed him, he had absolutely no idea about this surprise Profiles in Progress piece written by his friend and colleague. Welcome to the podcast, Deborah, and thank you so much for doing this.
Thank you for the invitation, and thank you for your kind words.
I must say, Deborah, that your piece entitled David M. Nathan, an epic investigator, epoch in diabetes care, really is beautifully written. It's thoughtful and thorough and clearly comes from a place of deep respect and friendship. So tell us a bit about your relationship with Dr. Nathan and how it has evolved over time.
Well, David is a very special person. I met him when I was a resident at Massachusetts General Hospital on the wards, thinking that I was interested in diabetes. And, some people you have to go and formally meet with and kind of, David, it was like you see him in the hallway, you said, hey, I'm interested in diabetes. And he said, come on, join us. And that is just the way he is. He's a very big tent sort of person. He is extremely generous, always there when you need him, but not at all controlling, which I think some people have those challenges with their mentors. That has never been an issue with David. I met him, as I said, as a really young person, and he was a great mentor, but we have evolved quite easily into colleagues over many years. I will say that the only problem with David, even though he is hands off, is that if you actually go to him with a problem, his first instinct is to just leap into action and try to fix it. He doesn't want to, he doesn't want to figure out or discuss. He's like, okay, how can I fix this problem for you? And we say, no, it's okay. We don't actually want you to fix it. We just want you to be aware of it or know about it. Don't fix it yet. So he really has that kind of roll up your sleeves and jump right in kind of attitude.
So a man of action, if you will.
Very much so. Very much so.
Now, in your article, Deborah, you outline all of his many accomplishments in the diabetes field to date and the tremendous impact all of that has had on diabetes care over time. We will be discussing some of these directly with him in the interview, even though he doesn't know that's why we're asking him. But beyond the accomplishments that we can all see on paper, are there any stories that you can share with us that highlight who he is as a person or some aspect of him that we may not see on the many stages from which he lectures?
Well, I think people do know that he has a great sense of humor, and that is one of the reasons he's such a popular lecturer. But actually, he really brings that to his everyday life. And he really handles ups and downs with incredible grace and equanimity. I don't think I've ever seen him kind of blow his top. Really, he's just very able to kind of take things in stride. He's also a truly excellent physician. He's incredibly compassionate. He really is able to relate to people from all walks of life. And he has been the PCP to many of his patients for decades. And although, of course, many very eminent people sought him out as their physician, he really continued to care for people whom he met many years ago, people with all kinds of challenges, and always is very motivated to try to, as I said, jump in and try and fix those problems for his patients as well as for his students and colleagues. So that is something that I think people might not realize just seeing him up on a stage.
And finally, Deborah, what would you like to say to David on behalf of yourself and other mentees? I think this will be a real treat for him to hear once he's gotten over the surprise of the Profiles in Progress piece that you wrote.
Well, I actually am not quite sure that it will be a treat for him to hear because he's always very embarrassed by compliments and always tries to kind of defer, push away praise. And so what I would say is it's all right to take a compliment as long as you don't inhale. Since he can't respond, I will say, I can say, I think confidently on behalf of all of his mentees, that we'd like to thank him for being such a warm and generous mentor, for always stepping in, for always stepping up. And most importantly, even though I think a lot of this has sort of a tone of kind of celebration as if he's not going to be around and participating, what we have all said to him is, you're not going anywhere. We really look forward to his continued mentorship and wisdom in coming years.
Absolutely. And I think the whole diabetes community would echo your words. He is absolutely going nowhere. This is merely a celebration of his accomplishments thus far, but obviously a whole lot more to come. So thank you so very much, Dr. Deborah Wexler. Such a pleasure to chat with you today. I encourage everyone listening to read the full profile in the April 2024 issue of Diabetes Care. And now let's move on to the interview with Dr. David Nathan. Remember that he has no idea that he was featured in the print at the time that the interview was conducted.
We just took a deeper dive into the GRADE study and additional insights that have been published in the April 2024 issue of Diabetes Care. And now, David, thank you for kindly agreeing to stay on longer for this one-on-one conversation with myself and Alice to share some insights from your many years of clinical investigation in diabetes that have really, truly shaped the management of both type 1 and type 2 diabetes.
Well, thank you for asking me. I'm not sure how important my contributions have been, but I've certainly been involved in some important studies along with numerous colleagues. Diabetes research, all research is a team sport, not an individual. So I will not even pretend to take credit for the things that have come out of the studies, but more than glad to address them.
And David, there you are being extremely humble. Your research career to date have included leadership roles in some of the most impactful studies in diabetes. I think of them like the Cher and Madonnas of diabetes. They're sort of studies you say one word and people know exactly what you're talking about. So DCCT, EDIC, DPP and DPPOS, Look Ahead, Today, and of course, GRADE, among others. Before getting involved in all of these huge multi-center trials, did you do other types of research?
Well, I started actually as more of a bench scientist than a clinical investigator during and after my training in the late 70s. So the kinds of studies that I was doing back then were laboratory evaluations. I helped develop some versions of the hemoglobin A1C assay. And then having developed that tool, having been at the bench, it was clear everyone knows that it depends on the tools you have to do your studies. And so I helped develop the A1C assay. And early on, one of my first big papers was looking at its utility, determining really whether it provided, now we all take it for granted what it shows. But back in the late 70s, it was a new observation. And so I helped demonstrate that it really did fill in information that clinicians did not have otherwise. It was also, to the extent that my career has been successful at all, I've been kind of in the right place at the right time. So back in the late 70s, there were pioneers developing things like early insulin pumps, for example. So I took those tools again, going from kind of the experience that I had in the lab, and used them as tools to investigate how to treat better, how to try to provide more physiologic replacement of insulin in type 1 diabetes. So A1C on the one hand, and looking at multiple daily injection regimens and trying to craft different ways of treating type 1 diabetes. So when the DCCT came along, as you may know, the DCCT was as clever as it was, hopefully, and led by Oscar Crawford. It was actually mandated by an act of Congress. People don't sometimes realize that. The National Diabetes Data Group and National Diabetes Commission, rather, actually was empowered by Congress, US Congress, to do a study that would explore whether we could reduce the development of complications in type 1 diabetes. And that's what the DCCT grew out of. I was kind of well equipped to apply for the grant. There were originally 21 investigators. It expanded to 28 investigators. And I was the kid I was the youngest of I want to say I've outlived them, but I've outlasted a lot of my colleagues who taught me enormously about the tools that they'd been doing. They'd been doing this kind of research for longer than I. But I was able, right place, right time, I was able to apply for the grant. I was one of the 21 original principal investigators. And I just threw myself into it because it was clear, I think, to many of us that this was going to be the most important study that any of us would be involved in. And it turned out to be the case. I mean, that we demonstrated, of course, before the UKPDS in type 2 diabetes, we demonstrated, because it was going along in parallel in type 2, but the DCCT in type 1 diabetes demonstrated, of course, as I think everyone knows now, that the intimate relationship between glucose control and the risk for complications. And we just had this remarkable benefit in terms of in the intensive treatment group. And again, that study was entirely owing to the contribution of its participants. I mean, they were just, and we follow them all to this day. 40 years later, we're following all of them. Those who haven't left in one way or another, but we follow all of them. So that's just extraordinary. And the story, keeps going. It is, I think, the most frequently cited paper in all of diabetes literature. And maybe, it's huge. I mean, it's got like 30,000 citations or something. And I had the opportunity. I was an English major in college, and I was asked by the leadership to kind of write that paper. So I wrote it, although it was a group effort for sure. But I was kind of the first author of it. And that was just being at the right place at the right time. And that the study, of course, was an enormous success. So that's how it started. And then subsequently, other opportunities came about. The Institute, you may recall historically that the previous largest study sponsored by National Institute of, it wasn't NIDDK back then, but was a study called the UGDP, the University Group Diabetes Program, which was just rife with controversy. It was a study that results were reported first in the Wall Street Journal before they were reported in the scientific meeting. I mean, it had a lot of financial implications. So the DCCT was in the wake of the UGDP, it was the big kind of successful study run by the Institute. And they subsequently, clearly in part because of the success of that study and how it changed the course of type 1 treatment worldwide and forever, started putting more money into the budgets for these studies. So the next thing in terms of my own career was that I was in a position, since I had some energy and a couple of ideas, to help propose with a few other people the idea of preventing what was then becoming the epidemic. Now, back in 1993 to 1996, when we planned the diabetes prevention program, it was becoming clearly an epidemic, but not nearly the epidemic it is now. And we thought that we should, turn our attention to seeing whether we could prevent type 2 diabetes. And that is the origin of the diabetes prevention program. And fortunately, again, the NIDDK supported it and has continued to support both the long-term follow-up of the DCCT, which is the EDIC study, now in its 40th plus year. And the same thing with the diabetes prevention program, which was stopped, I thought, a little prematurely because it was so successful after 3 years or so. But then we've been following them for another 20 years and hopefully generating important information. So that's how I started getting involved in these large studies. When the idea of GRADE came along, again, the Institute was very, very receptive to doing these studies, which, by the way, industry would not do. Industry is not going to do a study to prevent type 2 diabetes. At the time, there was no real benefit for industry because the pumps were in their infancy, really, to try to improve the care of type 1 diabetes. But the National Institute of Diabetes, Digestive and Kidney Diseases had the foresight and the resolve to, support these studies with many millions of dollars. And so my career is really owing to their generosity and their hopefully good sense in funding these studies.
That's really remarkable, David. And I'm just reflecting on a few of the points you made, starting at the bench and developing the hemoglobin A1C assay. And so really, there's roots in biochemistry, but also a passion for physiology and thinking about how to more physiologically replace insulin in your patients, and how using multiple daily injections, for example, insulin pumps, led to what we now understand as the intensive insulin therapy approach that has become the standard of treating type 1 diabetes. And the point you made about the DCCT was mandated by an act of Congress. And Alice and I, we did a special podcast episode last year on the National Clinical Cares Commission report to Congress that, now newly has come out. And this is directing many more questions, now more on the implementation of prevention and treatment of diabetes to decrease complications in our environment. How do we take all the lessons learned from the DCCT right on up through GRADE? And I think to the point Matt Riddle made in our discussion earlier about getting diabetes specialists available to patients with type 2 diabetes. And I guess I was sort of reflecting a bit on what the next opportunity you might imagine there being for a type of response to implement diabetes care more globally throughout our population affected with the disease.
Right. Yeah. So as we mentioned earlier, CMS took about 5 years, maybe more, maybe 6 years after we completed DPP to endorse the diabetes prevention program approach. So it's now paid for, assuming that programs really do follow the algorithm that we established. But they had to wait for data suggesting that it would save money. I mean, they have their own congressional mandates, and they can't. CMS and Medicare and Medicaid can't come out and endorse programs until it shows that it's cost effective, and that took a while to do, but they did it. I guess the analogy here for GRADE, and I'll go back to DCCT in a moment, but the analogy for GRADE would be to provide tools that help clinicians select the more appropriate medications for their patients. And by the way, we've done a lot of genetic work in DPP and in GRADE and DPP, and we haven't even introduced those factors yet. But as we understand more about clustering of risk factors in type 2 diabetes, as we understand more about the physiology of it, my hope is that we can, again, and it may take an AI approach, neural networking, artificial intelligence, because the number of variables involved are just numerous. And it may be too much for us to do just hypothesis testing to say, oh, by the way, the younger ones are the ones with more insulin deficiency, et cetera. It may really take some AI stuff. And so I think that going forward, to the extent that we can develop simple tools, you put in X number of factors, and the computer will tell you, based on high quality research, what would be the best medication to start with, and over time, how to change people. And I think that would simplify it, not only for specialists, but for not specialists, because as we all know, not even the majority of type 1s are treated by endocrinologists, and certainly most type 2s. There are 37 million of. This is the world's biggest issue, frankly, in terms of a common chronic progressive disease. Type 2 diabetes. I mean, worldwide, the population is, a 500 million, approaching 750 million people. That's just mind-boggling. And the idea of providing better tools, I think, is important. In DCCT, one of the things we were able to do, because we followed our wonderful group of participants for so long, and we followed them so carefully with eye photographs, whatever, we've actually developed kind of guidelines as to, for example, how often you need to do eye exams. So we published those, I think, maybe in the New England Journal also. In some great journal, we published them, whatever. But the idea was that since we'd followed them over time, we knew what their risk factors were. And it turns out if someone has very little minor eye disease and their A1C is in a really great range, like less than 7%, they don't need to have knee reflex, that may be the wrong term, eye exams, every year. Maybe that they can be seen every 2 years or 3 years safely without there being any likelihood for them to get advancing eye disease during that period of time. Conversely, if they actually have some initial eye disease and their A1C is not in a good target, they need to be seen even more often. So that's an example of where these trials can develop guidelines, rational, evidence-based guidelines that can help physicians figure out how to take care of their patients better. That's kind of part of precision medicine. So I think the same thing I hope will occur with GRADE. And we're just at the beginning of looking into those factors. The first 10 papers that we talked about earlier, I think, is a start of that.
It's always a pleasure listening to you talk because it's the passion comes out, right? That enthusiasm and that optimism is really wonderful to hear. And precision medicine, I'm a Star Trek fan. So I always, think about one day we'll tricorder whoever's in front and we can sort of figure out all of the parameters and exactly what the right recipe is for that particular individual. And right now we're using more crude tools to do it. But all the great research that you're participating in is hopefully going to give us more refined tools, which is fabulous. And I'm going to switch gears and ask you perhaps a silly question, but I think an important one for our listeners. So I've asked this of Herzl Gerstein, who is a good friend of yours. I was sitting on a plane with Herzl and I asked him the same question, and he gave me a very serious answer. And this important question is, how do you come up with the names of the studies? And I know that seems silly, but yet that's so important because the names of the studies are really how we refer to them as we're communicating with others. So, I mean, do you have a fun way or a silly way in which you come up with the names of these studies?
Yeah, I guess I don't find for Herzl's a very serious guy. I mean,
Very.
so you would give you a very serious answer, I'm sure. So some of these are kind of obvious. And I must say, I can't recall diabetes prevention program, duh.
Right.
We were trying to prevent diabetes development. So diabetes prevention program. But, we did program instead of diabetes prevention study because I think there was another DPS.
Mm.
All of these have pitfalls. DPP is also the name of, I think, a communist party in the
Oh
Philippines or
boy.
something. I mean, there are lots of, as soon as you come up with them, if you start searching, you can get into trouble. And that was pretty straightforward. Diabetes control and complications trial. We were looking at diabetes control and complications. So that, they kind of grew organically in a way. I must say that we have avoided the kind of silliness that you see in pharma. Who comes up with these Monjuro and I mean, I don't want to pick on them, and Wegovy and Ozempic, and they have firms, advertising firms that come up with these names, and I just, anyway. So we've done, I think, a little bit better than the drug companies naming their medications, and most of them hopefully are somewhat sensible. GRADE originally, as my colleagues will tell you, when I first brought up the idea of the GRADE study, and then had a number of very close colleagues, we met for a year and a half. The ADA sponsored our original meetings, by the way. So we should point that out before we got a planning grant from the NIH, but first the ADA sponsored it. And I had some kind of acronym that spelled out the GREAT study, GREAT. And my colleagues, fortunately, said, David, you're just asking for trouble. What if it stinks? What if it doesn't work out? You really don't want to. So we came up with this other GRADE, which stands for glycemia reduction approaches in diabetes. It's a little bit contorted, that one. The other ones, I must say, have been really great. Look Ahead. I didn't have anything to do with selecting that name in particular, but that was a great one. And it stands for something, of course. So I don't know what Herzl said, but, some of these are logical and some of them are just meant to be cute, I guess. That's how we do it.
And David, what would you say some of the biggest lessons you've taken away from your involvement in these mega studies? And not so much about the scientific content or output, but other important lessons that you've learned.
So as much as I am pleased and proud of the advances that I've helped contribute, but it's not me. As I said, research is a team effort. And I think assembling a group of well-meaning, intelligent investigators who share a common passion and goal to do the research is critical because they're going to be working on these studies more than they are ever paid as part of their salary. They work hundreds of hours a week, for God's sake. There's nothing in the salary. So you need to find like-minded individuals who are at least passionate about the work. Within that, you do not want to accumulate a group of investigators who all agree with one another. And I must say that, initially I remember, and some of these studies, the DCCT, we met for more than a year and a half and met in Washington at least every month. We're talking about, 16, 18 visits that we took, these investigators. And all of them, mostly men, few women at that point. Now we're much more diverse, of course, which is a great thing. But each one of them, their mothers had told them they were a genius. And therefore, they all, felt that whatever they were saying was correct. And I think that it takes a certain kind of leadership. For the DCCT, was Oscar Crawford, for sure, to basically take the best out of all of those diverse inputs and then distill them into a study that really doesn't lose sight of the primary hypothesis, the question being asked, and hopefully then results in a good answer and an interpretable answer. So that's one thing. I think it's a team sport, respecting your colleagues, listening to them, but also making sure that there's someone who can drive it in the direction that it needs to be. So not losing sight of what the hypothesis is. Beyond that, of course, the major, and I've not mentioned this at all, but the people who run these studies are the coordinators. So we shouldn't lose. I thank people earlier, my investigators and the NIH and the participants, of course, but the real people who run the studies, who have the direct contact with the participants, who are both lab technicians, nurses looking after the health of the patients, making sure things are done correctly, making sure the measurements are done correctly, doing the measurements. Those are often nurses, most often nurses, but coordinators, nurse coordinators. And making sure that they are not only kind of part of the discussion, but they are central to the discussion, because they're the ones that know the participants, know what they can do and what they can't do. And they, after all, carry out the study. So I just can't leave them out, nor all of the other staff at various clinics in these multi-center studies. Without that, we don't get the data, we don't collect the information in a timely fashion. If it's not collected correctly and uniformly, the study doesn't happen. And then, of course, all the laboratories and the statisticians, the coordinating centers, they really coordinate. That's what they do. They're not only biostatistical centers, but they really coordinate these very complicated studies and make them happen. So I think that honoring and respecting and making sure you understand how vital those groups are to the success of any of these studies is key to their overall success.
Excellent words. And for a young investigator listening to this right now, any words of wisdom you wish someone had told you when you were starting out in your research career?
Yeah. So when I was starting out, as I said, I was in a laboratory environment, and there were very few people doing, believe it or not, doing kind of pure clinical research, which is what I evolved more and more to. I still have a hand in the lab. I developed assays and used them, but I was really pretty much one of the earlier wave of people whose careers were predicated on clinical research. There was no advancement at Harvard unless you were in a lab. I mean, it just wasn't heard of. So these days it's very different. So I think that that's terrific. I would say that I've been, again, to the extent that I've had success in my career, it has been fortuitous. I've been at the right place in the right time and given the right tools and, given the right opportunities, blah, blah, blah. I think that those opportunities are actually even more easy to come by these days than they were 40 years ago when I started, because clinical research is a real big deal. And it does, there is a pathway at Harvard as well as everywhere else for advancement for people doing clinical research. And I would just say that I think that the career that I ended up fortuitously pursuing has been so rewarding. And being able to answer, it's all about asking questions and answering them, being a problem solver. And to do that and actually seeing the benefit in terms of people's health care and their health, there's no better feeling. I mean, it's just, how can you do better than that? Do things that you love to do and actually they benefit people. So I've just been really incredibly fortunate to be able to have that career.
Well, it's just been wonderful speaking with you and hearing your experience and reflections on your esteemed career, and also how important the environment and the people that you've worked with have really been to all of the successes of what we now have learned and can apply to the treatment of patients with diabetes. I want to thank you so much, Dr. David Nathan, for taking the time to chat with us today. And once again direct our listeners to dive in deep to the April 2024 issue of Diabetes Care for more details. Let's move on now to our rapid exchange segment where Alice and I chat about some of the articles we found particularly interesting this month.
To get us started, my first pick is about breastfeeding and cardiovascular disease risk. In the general population, we know that breastfeeding duration is inversely associated with cardiovascular disease as well as type 2 diabetes risk. However, this relationship had not been looked at specifically in women with gestational diabetes or pre-existing type 2 diabetes until now. Dr. Anna Birakov and colleagues from Harvard University utilized data from two prospective cohorts of women from the Nurses' Health Study 1 and 2, including over 15,000 Paris women with type 2 diabetes and over 4,500 women with history of GDM. They found that longer lifetime duration of breastfeeding was inversely associated with CVD risk, independent of BMI, family history of CVD, physical activity, alcohol intake, socioeconomic, and smoking status. For those with GDM, the inverse association persisted even in women who did not go on to develop type 2 diabetes. To give some numbers, among the women with type 2 diabetes, those who had cumulatively breastfed for more than 18 months had 32% lower CVD and 38% lower coronary heart disease risk compared to women who had never breastfed. And for those with GDM, the reduction in risk was 51% for CVD and 62% for coronary heart disease. Potential mechanisms of benefit were discussed in the full article, linking breastfeeding with favorable glucose and lipid metabolism, inflammatory profile, and stress response. However, these effects are only present during breastfeeding itself, which is brief relative to a woman's lifetime, which makes me wonder if the immediate postpartum period is particularly detrimental to future cardiovascular health and that breastfeeding may attenuate that. Just wondering out loud as possible explanation.
Wow, Alice, those relative risk reductions for cardiovascular disease are huge. And here's even more reason to ensure women receive the support they need to breastfeed, both in terms of time and resources, and not just for the health benefit of their offspring, but for themselves. Also on the topic of cardiovascular disease, Dr. Mahmoud Al-Rafi from the Houston Methodist DeBakey Heart and Vascular Center in Texas and colleagues pooled almost 15,000 participants from 4 prospective cohort studies with coronary artery calcium scores who had either normal glucose tolerance, prediabetes, or diabetes without known cardiovascular disease at the time of coronary artery calcium scoring. They observed an increased prevalence of having a coronary artery calcium score of greater than 100 already among those with prediabetes relative to those with normal glucose tolerance. And this finding in prediabetes was further associated with a more than 60% increased risk for incident clinical atherosclerotic cardiovascular disease, a risk similar to that for individuals with diabetes. So these data support already considering the use of a coronary calcium score for cardiovascular disease risk stratification among those with prediabetes, as some may already have the same cardiovascular disease risk equivalent as individuals with established diabetes.
And I think these data really remind us that the definition of diabetes is currently based on the risk of developing microvascular complications, but the macrovascular complication risk starts way earlier than that. And this actually beautifully segues into my next pick, which is kind of along the same lines and thinking more from a pathophysiology perspective. It's a fantastic review article by Professor Naveed Sattar and colleagues looking at the contemporary understanding of the role of excess adiposity on cardiovascular and kidney risk in persons with type 2 diabetes. And by virtue of what you just talked about, Mike, a lot of this could probably extend even into the pre-diabetes state. They do a beautiful job of reviewing the evidence from epidemiology, changing trends in complications, genetics, and treatment effects from cardiorenal outcome trials that support the hypothesis that excess adiposity, particularly in the form of ectopic fat, is an important driver of cardiorenal metabolic conditions and therefore an important target of early intervention. This concept of ectopic fat, in other words, fat distributed throughout the peritoneum, liver, pancreas, heart, skeletal muscle, kidneys, perivascular, etc., is an important one for us to recognize and communicate better because clinical measures like the BMI can miss it, which can then make it more challenging to convince people of the benefits of weight loss. And I certainly see that in clinical practice. If you have someone who by, quote unquote, societal standards would not be considered as someone having excess weight, trying to explain that weight loss is still beneficial, that can sometimes be challenging. And this really aligns with the ADA EASD consensus report, which has elevated weight management as one of the 4 critical components of care in type 2 diabetes. But arguably, we need to be implementing these strategies way more upstream, before the development of type 2 diabetes and other complications. They also go on to discuss the role of SGLT2 inhibitors and GLP-1 receptor agonists and potential mechanisms through which the cardiorenal benefits are achieved. It's a really well-constructed review, and I certainly encourage everyone to read it.
And related, Alice, individuals with familial partial lipodystrophy develop excessive ectopic fat deposition due to an inability of their subcutaneous adipose tissue to accommodate energy storage. And like those you mentioned, they may have a normal body mass index, but severe underlying metabolic dysfunction. And Dr. Maria Voss-Freitas and colleagues at the University of Michigan in Ann Arbor evaluated the effect of GLP-1 receptor agonists in 14 individuals with familial partial lipodystrophy and observed reductions in body weight, body mass index, hemoglobin A1C, fasting glucose, and triglycerides after 6 months of therapy. Triglycerides were reduced more in individuals with familial partial lipodystrophy than in a comparator group that was included in the study of 14 individuals with type 2 diabetes. Now, 2 of the individuals with familial partial lipodystrophy developed pancreatitis with longer-term treatment after the 6 months, although both had had a history of prior acute pancreatitis, which is common in this population. It frequently presents with markedly elevated triglyceride levels. And so while the potential benefits of GLP-1 receptor agonist intervention were observed, there is still need for cautious prescribing for those with factors that do place them at increased risk for future pancreatitis.
And this study is interesting because this is a group of individuals where we don't entirely know what exactly or how best to help them, I guess maybe the best way to describe it. So I think these data are very helpful to direct us, but always with the caveats of caution that we have to implement with any clinical decision. So that was excellent. Thank you. Now, my last one is particularly timely given that this episode is being released still during Ramadan. So Dr. Mohammed Al-Sofiani and colleagues from Saudi Arabia performed a real-world prospective study of the effectiveness and safety of automated insulin delivery compared with other type 1 diabetes treatments during Ramadan, which is essentially an intermittent fasting kind of process. They looked at 294 people living with type 1 diabetes who were either using AID or pump with CGM or SMBG or MDI with CGM or SMBG. The outcome of interest were predictors of fasting most days, defined as breaking the fast on 2 days or less. So compared to MDI plus CGM, the automated insulin delivery users were more likely to complete fasting most days of Ramadan with an odds ratio of over 2. Now, among those using CGM, the AID users had greater time in range, lower glucose management indicator, time below range, time above range, as well as average glucose. In addition, the double target of fasting most days and maintaining a TIR of 70% or greater during Ramadan was achieved by 53% of AID users compared to only 3% of conventional pump users and 44% of MDI plus CGM users. These results make a lot of sense, and I think really highlights the utility of automated insulin delivery, particularly during times of prolonged fasting and variable eating.
Really agree, Alice. This is an impressive benefit for utilizing automated insulin delivery during the observance of Ramadan, and especially the reduction in hypoglycemia, which is a big concern for patients during this time. And as the holy month continues through next week, I want to just also remind our listeners, consider the increased risk as well as for hypoglycemia that this study addresses so well. There's also risk for ketoacidosis with prolonged fasting, and ketone monitoring for any patient feeling unwell, especially if they happen to also be taking an SGLT2 inhibitor agent, is certainly worth keeping in mind. Now, in the area of SGLT2 inhibitors, Dr. Siham Abdelghani and colleagues from the University of Texas, San Antonio examined the effect of 12 weeks empagliflozin treatment on liver fat content in 30 individuals with type 2 diabetes and 27 individuals without type 2 diabetes using a 2-to-1 randomized double-blind trial design. In both groups, they observed reductions in liver fat content that were correlated with greater baseline liver fat, greater reductions in body weight, and greater improvement in insulin sensitivity, but not with changes in hepatic glucose production measured by isotope tracers or in fasting glucose or hemoglobin A1C. So the glucose homeostasis was not changed significantly, but the effect on the liver in reductions of liver fat suggests this is another organ that could be protected via a glycemia independent mechanism with SGLT2 inhibitor therapy, and certainly warrants further investigation.
And I think it's been interesting to watch over the last number of years and will continue for the next number of years, the strong interest that in the diabetes field we're now placing on fatty liver disease, or what's now called metabolic dysfunction associated steatotic liver disease, or MASLD. And I think we're going to see more and more publications and paper, and really a combination, I think, of the diabetology field and hepatology, because we really also need to be discussing with our colleagues. So that's great. Thank you, Mike, for this. And this brings us now to the close of our April 2024 episode of Diabetes Care on Air. We had the opportunity to discuss the important collection of papers from GRADE with Drs. David Nathan, Jennifer Green, and Matt Riddle. We also heard from Dr. Deborah Wexler about her beautifully written Profiles in Progress on Dr. David Nathan. And of course, we heard from Dr. Nathan himself, without him knowing about the piece ahead of time. I hope you enjoyed the surprise, David.
And remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications when new episodes come out, and thank you for listening.